Hi, welcome to podcast Pantai Hospital Ipoh, Voice of Care, Caring from the Heart. I'm Zikril, your host today. I'm a Clinical Services Development Manager and also perfusionist. We are having here our Cardiothoracic Surgeons Associate Professor Dr. Ahmad Zuhdi, who will be sharing about what is cardiothoracic is all about. Welcome Dr. Ahmad Zuhdi for this podcast. And I also would like to congratulate you because recently Pantai Hospital Ipoh already done the first case in Perak, which is our minimal invasive CABG case and also our minimal invasive valve case. Okay, Dr. Zuhdi, we have questions here. Could you explain in simple terms what a cardiothoracic surgeon does and when surgery is needed?
Okay, thank you. First of all, Assalamualaikum, very good morning, salam sejahtera semua. So, my name is Dr. Ahmad Zuhdi, Cardiothoracic Surgeon in Pantai Hospital. I think we go straight to the question. Basically, what does cardiothoracic surgeon do? We are surgeons. Basically, people with heart disease come to us for operation. So, of course, all these cardiac disease, there are many ways of treating them. So, they have like severity and the complicatedness of the disease. So, the severity of disease that cannot be controlled or mended by medications or by the cardiologist, then they are referred for me to operate on. So these are the case with complex disease usually. Okay, so our main operations are bypass surgery, valve replacement surgeries, and so on.
Apart from that, is there any other surgery under cardiothoracic surgeons?
Yes, we also cover the lungs also. So kita operate on the lungs. Many conditions of the lungs that need operations, we also do them. Some lung cancer also, we do operation on lung cancer patients with infection and accumulation of fluid in the lungs. Oh, not in the lungs, in the chest. So those kind of patients also we operate on.
Cardiothoracic surgeons and cardiologists. So what's the difference?
Okay, so is to sort of simply explain it is we just follow the flow of the patient. So if the patient comes to the hospital, of course, they're going to be seen by the cardiologist first. So the cardiologist will manage from the beginning, do all the workup, make diagnosis, and then plan for the next management. So all these patients, usually if they have like heart disease, for example, coronary heart disease, they come with a heart attack, for example. So they are managed by cardiologists. Cardiologists will give them medications, will run tests to find out, to diagnose the disease, which include echocardiogram, angiogram. And if the disease is suitable for their intervention, then they will intervene first. For example, stenting lah. So we know if the patient has like single vessel or two vessel disease, simple disease, then the cardiologist will do the stenting. But for more severe disease like triple vessel, disease that involve the main branch, then this patient will be referred to us, cardiothoracic surgeon, for bypass surgery.
What is your advice when the patients come and see cardiologist, then the cardiologist asks to do bypass, but most of the patients refuse to do that bypass. So what is your advice to those patients?
Okay, first of all, it's understandable. All over the world, we see, not just in Malaysia lah, or even in Europe and US, what we call take-up for cardiac surgery or bypass surgery is lower than what it's supposed to be. That means, let's say if 100 people, 100 patients are referred for bypass surgery, about 30% will decline, will not go through bypass because they're afraid of the surgery. So stigma attached to surgery, that surgery is big, it's very invasive as compared to lesser procedure like stenting, multiple stentings. We know already that from research and all that, we know already in certain cases surgery is better. Surgery is better in terms of long-term outcome, immediate term outcome. For certain diseases, bypass is much better, and patients post-bypass will do better. But of course, the stigma that operation is big and stenting is lesser, overcome that. Patient don't see that. Patient don't see the long-term outcome. So many will refuse to go surgery because they think it's a major thing. Of course, I can't deny that it's a major event or major thing to go through for your life. But if you look at long-term results, in what we call intervention free, if they go for bypass, then they are free from events, free from coming to hospitals for the next 10 15 years. They don't see that and they don't consider that important. So I think that's one of the factors that, or main factors that determine why patients are usually afraid and don't come for surgery, even if the disease indicate them to do so.
Okay. I assume patients getting scared having bypass surgery, maybe because of they do not know what is the flow. Can you walk us through what a patient's experience before, during, and after surgery?
Okay, so as I said before when I talk about when patient comes for certain heart disease, then they go and see the cardiologist first, and if these diseases need surgery, then they are referred to us, of course, and then they will see us first, either in our clinic or I will review them in the ward, explain to them what is needed, why these patients have to go for surgery, and then explain to them what are the sort of I usually explain them in detail, so what it involves, when do they need to come in, and what surgery involves, and all the risks associated with this procedure. So normal patients that need, for example, bypass, usually they see me after the diagnosis by the cardiologist, and depending on the severity and urgency, then we plan for surgery. For more urgent case, we do the surgery straight away when patient is in hospital. For lesser urgent ones, we give date. We set up a date, so the patient will come in 1 day before the operation, 1 or 2 days before the operation for preparation. Surgery will take place in the morning on the operation day, and then they spend the time in ICU after the operation for 1 or 2 days, and then back up to the general open ward for about 4 or 5 days for recuperation, for physiotherapy, for them to recover from surgery. And once they are back on their feet, if they can go to the toilet with minimal assistance, if they don't need oxygen, if the pain is well controlled, then they are free to go home. So the whole process will take about 7 to 10 days. Some people, it depends on patients to patients. Some patients do very well. Some of them go home 3 days, even 3 days after the operation, regardless of the age. Some elder people go home earlier than younger people. So there's no saying that older people do worse than younger people. It depends on how they do, motivated they are after the surgery to get back to the fit, and they can go home early.
About the risks and complications, is there any preparations or steps you take to minimize risks and also avoid any complications?
Of course, there are a few factors that can increase risk during operation. We always say that these are the modifiable and non-modifiable. So like modifiable risk factors are like smoking. Patient cannot smoke before the operation. Of course, by right, they cannot smoke for the disease. They cannot smoke at all. But for the operation, they have to stop smoking for at least 2 weeks before the operation. Otherwise, the rate of lung complication after the surgery is higher. And then they tend to get lung infection, or a lot of sputum coming out after the operation if they keep smoking. Another thing is the sugar control, because most of the patients have diabetes. So we try to control the diabetes before the operation. Many patients, their diabetes are not well controlled, the sugar level. So we try to control that as much as possible before the operation. Again, if the blood sugar control is poor, then this increases the risk of operation, mainly wound healing and infection. So these are things that we are worried about. They have to monitor their sugar at home, control their diet. But at least, I think for me, at least 2 weeks or so before the operation. And you can see that this patient, if the sugar control is better, then the rate of complication is lower. Okay, other risk factors that I say is not modifiable is the condition of the patient in general. So the heart condition, whether the strength of the heart is low. If you have a weak heart, then of course the risk of operation is higher for you. And of course age, you cannot run away. Older people usually have higher risk, but not saying that, again, it depends on patient to patient. If you are 70 years old but you look like 50 years old, you are very active, very strong physically, then you do very well. Again, case to case basis. But overall, the risk for surgery in a good patient, good heart function, not much of risk factors or good control risk patients are very low nowadays. I mean, cardiac surgery has been around for 40, 50 years. And it's becoming like a routine operation. And all the procedures, all the techniques are very safe nowadays. Although it's a big operation, it's because it's operation on your heart, but the risk is around 1% only, overall risk. We call it mortality risk. So around 1 to 2%. So that is very good for such a major surgery. So that is something that people don't know. They think that they come for surgery, the risk is like 50-50 of making it. No. So the risk is around 1 to 2% only.
Okay. Previously, we are talking about minimal invasive. Does it, the minimal invasive things also can reduce the complication or risk? Or what's your point of view having this minimal invasive surgery?
So the thing about the conventional technique is that we have to cut the breastbone in the middle. So that interferes a lot with the patient's physical activity after the operation. The bone needs about 1.5 months, 6 weeks to heal and get the strength back. So that is quite debilitating for the patients. Of course, they can go around, walk around, but they cannot go back to work, they cannot drive, they cannot even sleep on their side for at least 6 weeks. So that is quite an important limiting factor for the patient. So they have to be off work also, especially if they work. They don't work in office. The main income is, like they work on their own, basically. So that is a major factor. Another thing is these wounds, all wounds are at risk of getting infected. Whether it's high risk or low risk, all wounds are at risk of getting. But if you get infection of the sternum, of the chest wound in the middle and involve the sternum, then it's going to be very complicated, because then they have to come to hospital, get dressing done, and then sometimes we have to rewire the bone. It takes a long time. So it's a major, what we call morbidity. But if you avoid this approach, then you avoid cutting the bone. Not only you avoid that 6 weeks of resting time, so you patients can go back to the normal activities earlier. If you get infection there, it's usually very self-limiting also. So that is...
Is it as early as discharge day?
Some patients go back early on the conventional. If I have to be honest, some patients go back early on the conventional. So I don't think in the very short, the immediate post-operative, it doesn't make much difference on the discharge day. Probably 1 or 2 days only. But in the mid-term, got sort of improvement after 2 weeks. With minimally invasive, you're back on your feet, and then you can drive, you can go back to work as opposed to. So you, all in all, you save about 1 month, let's say, if you go for a minimally invasive.
Compared to conventional.
And again, and going back to the first thing that we discussed, that many patients turn down surgery and prefer stenting because of this invasiveness of cardiac surgery. So with minimally invasive, we try to sort of narrow the gap of invasiveness between operation method and non-operation method like stenting and all that. So we try to reduce the gap so that the patients are less scared or not stigmatized anymore in that sense. Okay.
Okay. Do you know any myth about cardiac surgery? And if there is, what you will say about that?
Okay, so the myth, there are not many myths. Most people are misinformed or uninformed. Information. So as I said before, surgery, for most cardiac surgery, the risk is not that high. It's not 50-50 or not even 20%. Even if it's 20% or more, then we as cardiac surgeons also won't offer the surgery. Okay, so the risks are very low nowadays. That's one. And I think that people always ask me, if you do surgery, you take out the heart.
Okay.
So no, we don't do that. So the heart is in place there, but we operate on the heart when it's intact. So we don't take out the heart and then put it back. No. Okay. So those are the most common sort of mythical questions.
Yeah. But we do stop the heart, right?
Sometimes we stop the heart. Depends. It depends on the technique that we use. Like myself, I do so many techniques because for me, you have to be versatile. Depends on what case that you are facing with. So if this case we think it's better to stop the heart, then we stop the heart. If this case you think I think it's better not to stop the heart, then I don't stop the heart. I do the heart beating. I do the operation with the heart beating without stopping the heart.
Okay, thank you, Dr. Ahmad Zuhdi. The last question, not the last question, just a request from you. What is your advice to the public who are having heart problem?
Of course, general advice is to take care of yourself. Avoid all this sedentary lifestyle like smoking, bad eating habit and all that. But specific to cardiac surgery, at least come and see me. At least come to see if you are being referred to have cardiac operations, then come and see the cardiac surgeon and then get explained. Ask whatever questions that you want to ask. And then usually the thing about our culture our
Malaysian culture?
Malaysian culture that listen to outside people more than we listen to the professionals. So usually what happens is that when a patient comes in, referred for surgery, and then we offer them surgery and they agree for surgery because they just had an attack, so they're afraid that of that heart condition. But they go back and they start seeing people outside, they start talking to friends, and then they say, oh, don't do cardiac surgery, you take this. These are all non-proven, based on hearsay, and based on what people, it's passed from individuals to individuals saying that, oh, you don't need surgery, you do this, you take this better. So these are the common trend that we see. And it's unfortunate. That's why we're trying to reach out to people more. If something works, then we would practice it in the hospital. That's the bottom line. So if you don't practice in the hospital, then usually it doesn't work or it's not proven to work. And sadly, most people offer things that only offer hope without evidence.
Yeah.
So that's...
Please see the correct people.
Yeah, and do your correct research also. Don't just read from Facebook or whatever. You have to go to the specific sites or information source that you can.
Thank you, Dr. Ahmad Zuhdi, for having us in our podcast. Don't forget to follow us in our social media, Facebook, IG, TikTok, LinkedIn, and also our YouTube channel. Bye.